Good morning for all you Facebook followers of Dr. Ohl and things COVID and other viruses. It's March 9th, and boy, what a pretty drive in this morning. Daffodils are blooming. All the red buds are out in full glory. The cherries, forsythia, it's spring, height of spring. That reminds me that it was the height of spring 3 years ago when we had our first cases of COVID here in North Carolina. So 3 years of, roughly, a little under 3 years maybe, of pandemic. I think right now as we slide out of emergency pandemic mode and more into endemicity mode, it's time to start looking back a little bit over the last 3 years. And some of that is somewhat painful. There are things we don't want to remember. But there's a lot of lessons learned. And the big thing here is that emerging infections are still going to occur, and some of these will result in pandemics. And so this one isn't the last, and we need to take note and really do what we call in the military a hot wash, and look at what we learned, what worked, what didn't work, what were big mistakes, and so that we can be ready for the next one. And you're starting to see a little bit of this discussed in the media. A few points about it. This should be done throughout public health, in government, and in science. And all of the social aspects of our society and culture also should be involved because, as we'll talk about in a minute, they are all impacted about how we respond to emerging infections and pandemics. The one thing that doesn't really belong at all in this discussion is politics. And I'll just leave it at that because it's just not helpful and could really get in the way of how we respond in the future. One thing to note is that politics have entered in in the last 2 years to start dismantling public health. And there's a lot of states and a lot of areas now where public health is in such a spot because of new legislation that's been put in that is really going to hamper the response to any future pandemics. And that includes dismantling quarantine law. Quarantine is a useful tool to limit the spread of infectious diseases, and not just COVID, but anyone, measles or smallpox if it should ever come back. Tuberculosis, we use it all the time. And so we need to be able to still be able to do that. It doesn't mean that quarantine shouldn't, needs to be done wisely, and it needs to be done in a way that's pertinent. And when it's not needed anymore, it should go away. But dismantling public health is not going to be a good thing for our society, particularly as people become more vaccine hesitant or more anti-vaccine. We're going to start to see childhood diseases come back again, and measles is an example of that surfaced. And public health needs to respond to those outbreaks when they happen and curtail them. Otherwise, in 10 years or so, we're going to be in a heap of trouble, and it's going to look like the 1950s again here in the United States as far as communicable diseases go. I'm a little bit more optimistic. I think that people will wise up, and that's not going to happen. But we need to be cautious as we come out of the pandemic here and start looking at the future. So some things that, just to go back over the last 3 years and refresh our memory. Early on, as COVID started spreading very quickly, and we started seeing people dying in fairly large numbers. And in the northeast part of the United States, in Seattle, this is where it hit first here. That was a problem in March going into April. And the hospitals were full in New York. And I know because I talked to the doctors in New York, and they're still scarred by it. There's PTSD in the medical people up in New York City. And it was the elderly people and people who were had underlying medical problems who were dying. Nursing homes got hit hard. In fact, I imagine even amongst our viewers, probably most people know somebody who died during the early days of the pandemic. Because of that, and because of what we were also seeing in other countries, particularly Italy, where they were lining up military vehicles to take caskets to the morgue, we went into a lockdown mode through most places in the United States. Some places were a little bit more strict about it than others. But what was locked down was done to encourage social distancing so that people weren't next to each other. So it's pretty simple that if people aren't in close proximity to each other, the odds of them spreading a contagious infection from one to the other is a lot lower. And that was a tool that we used. And then we also used fairly rigorous case identification and quarantine of people who were contacts, because a person who was a contact would have a 20 to 30% chance early in the pandemic of getting the infection. And so if you quarantined them, then they don't spread it to other people if they get it, that 20 to 30% of the time. This is a tool of public health that we have been doing since the early days of plague, and it works. So if anyone tells you that testing, quarantine, and lockdown type social distancing doesn't work, they're just flatly wrong. It does work. And if you remember, the term we used was to flatten the curve, to push down that peak of the epidemic curve. And it worked. And we were trying to buy time, in order to understand the virus better, to understand transmission, to study it better, to know a little bit more about what we could do, what we couldn't do, and most importantly was develop a vaccine. Now, there's a lot of criticism of lockdown right now, and lockdown wasn't particularly fun for most people. Some people got a garden in and did some home improvement and stuff, but I worked. It didn't change my life one bit, but it worked. It flattened the curve, and it really blunted the number of serious infections and deaths, and it gave our hospitals a chance to prepare, because it takes a while for the hospitals to ramp up. If you remember, we didn't have enough what we call PPE to protect our healthcare workers. That's the gowns, the gloves, and the masks. We had to make that stuff and get it out there. We had to learn a little bit about treating the virus. We got some drugs out to help early on. Remdesivir, which has a modest effect in limiting viral replication in people who have COVID. We were able to get our ICUs ramped up and increase what we call our surge capacity, and get our emergency departments beefed up so that they could see more people too. That's why lockdown happened. It didn't happen because of overreaching. It didn't happen because we wanted to punish society it didn't happen just because people wanted power or control. It was to limit spread of contagion, and it worked. Now, some areas of the U.S. Lockdown, or I could even say not even just the U.S. but the world, lockdown lasted longer than it needed to. Probably the best example of this was China. I mean, they were doing full-scale lockdowns until just this past December, and that turned out to bite them because when eventually you have to stop doing that, and when they did, they had a huge surge of COVID. Luckily for them, that surge of COVID that happened in the last 3 months in China was of a less virulent or less mean virus because the variant that was circulating there wasn't as serious. But early on, you have to remember the death rate, the absolute mortality due to COVID was 4% in all comers. It's 4 out of 100 people who got COVID died. And the initial virus was meaner, but we got through that. I think here in the United States, there were areas that probably took lockdown longer than necessary. Maybe California and some of their areas. More populous areas, I think, extended it longer than others. Here in North Carolina, I think we threaded the needle really well, actually, because it was around about May when we started relaxed lockdown, and we did it in a graduated way, started opening up businesses. And some of them, particularly bars and restaurants, would limit the number of people or change the way the seating was in them and such. But we started to relax in the early summer of 2020. And by the end of the summer, things were getting a little bit back to normal for business and industry. Some of the hardest hit areas were facilities and factories that we absolutely need to function, meat packing plants, food delivery, and such. And if you remember the toilet paper shortages, the paper towel shortages, these were areas too that got hit. And the people who worked in those places, they couldn't lock down. They had to keep going to work. There was a lot of COVID going around. And this really hit a lot of our marginalized communities pretty hard, particularly the Hispanic communities and people who are socially economically disadvantaged. They couldn't afford to not go to work. And they got more COVID, and they had more impact, both as far as serious disease, long-term effects, and death. As time went on, if you remember, it was by the end of 2020 that we got our first vaccines. And this is really a triumph of man and human ingenuity and technology. Because if you want to think about it, as sometimes I do, as a war between contagion and germs and humans, we all have our different weapons. Germs and have their way of making people incredibly sick. They have their way of changing their genes so that they can become more resistant to treatments and therapies. But we as humans have technology and ingenuity. And the fact that we were able to get two good vaccines that had a high efficacy and a very good safety profile out by the end of 2020 is just incredibly remarkable. Yeah, there were a few things we learned about the vaccines, some rare side effects. All vaccines and therapies will have very rare side effects. But we in infectious diseases look at risk-benefit ratios, and the benefit of being vaccinated and immune to COVID clearly outweighed any of the risks that we saw with the vaccine. And these vaccines are still being used and being modified here and there in order to cover our current variants, but they're still out there and they're here to stay, I think. The thing that was interesting is the early studies were pretty clear, and we were able to get them done pretty quickly. Why were we able to get the vaccine studies done pretty quickly is because there was so much COVID around. We didn't need to wait long to find out if they worked, because when you study it in a population, you have to study people who got the vaccine, people who didn't get the vaccine, but so many people were getting COVID that the numbers that we had to look at got high enough fairly quickly. And so that's why we were able to get them out. Early on, there wasn't enough vaccine. Remember the lines? Remember we had to prioritize. First it was healthcare workers, and then other critical infrastructure workers, and then finally we could get it out to everybody. Pretty much everybody could get it by April or May of 2021. And our initial coverage of the vaccine was pretty good overall. Could have been better in some areas. But here in Forsyth County, we sat in the mid-70s. Elderly people, because they were scared, they were much higher. Younger people a little lower, which turns out may have been okay, because as we learn, younger people, particularly kids, didn't quite have as much serious consequences of COVID infection. Eventually, we got vaccines for kids, and then from there on, it was mostly downhill. I say mostly because there were some left turns in there that we didn't expect, and most of this was because of mutations in the virus that created new variants. And as the virus created new variants, it was able to evade immunity either from the vaccines, the initial vaccines that we had out, or from natural infection, because the virus was a little different. The antibodies didn't quite attach to it quite as well. So some people got COVID more than once. Usually it was and I know a lot of people who got it more than once. For most of those people, the second time around wasn't as bad because partial immunity helped protect them. But because of the variant and the change in immunity from that. Now, some people says that natural immunity is better than vaccine immunity. It turns out that they're actually probably about the same. And if you had infection and then got vaccinated, you're even better off yet because you got two immunologic powwows to get you going. And so now if you look at our populations across North America, probably upwards around 90% or so of people have some level of immunity to COVID. And that comes from either natural infection or from vaccination and boosting. Because of that, our case numbers aren't as high this time around during respiratory viral season. Our numbers of hospitalizations due to COVID were not as high as during previous respiratory waves. And so we got through January and February, actually better than I predicted we would. And our case numbers now continue to decline, albeit slowly. Our number of people who have COVID in the hospital continue to decline slowly. And about half of those actually are in the hospital for another reason, not just COVID. But interestingly, the people in our hospital, the majority of them are still people who have not been vaccinated in the past or boosted. And our wastewater numbers are going down. So I started out this little discussion talking about spring. This is usually heralds the beginning of the end of our respiratory viral season, and I think that's what's happening right now. So I anticipate our COVID cases will continue to decline. Will they go away entirely? Never. We'll have COVID with us forever. But as our immunity continues to get further strengthened by repeat infections, as we tend to get more booster vaccines, more about that in a minute, and as potentially the virus continues to change, and hopefully in a less virulent way, this will end up now becoming one of those viruses that we deal with every respiratory viral season. And for the vast majority of people, it'll cause colds. Now, some people, even if they get a cold, can get really, really sick. And these are immunocompromised people. These are people who have a lot of underlying problems, people with cancer, transplant patients, so on and so forth. And they will continue to be vulnerable, not only to COVID, but our other respiratory viruses. I've seen the common cold virus kill an immunocompromised person. And so I think one thing we got to start working on and thinking a little bit about more going into the future is how do we protect the vulnerable people in our society from contagious diseases? Before COVID, we largely left it as the responsibility of that individual. But I think we can help them a little bit also with other things. One of those things to help these people are masks. Now, masks have become a big political thing and a subject of huge controversy. I'm an infectious disease doctor, so I'll just put it out there. I'm a mask guy. I've been wearing masks for my whole life and career in medicine. And why do I wear masks? Is to not get infections from other people. I go into a room of a patient who has tuberculosis. I wear a mask so I don't get TB. If I go into a room of a person with measles, I wear a mask so I don't get measles. They work. I can tell you they work. Because we've been using masks in healthcare for decades and decades to protect ourselves from airborne viruses and bacteria. And we will continue to. Now, society at large can do the same thing. They can wear masks to protect themselves from viruses and bacteria, from all those cruddy germs that other people around them might have. And immunocompromised people, I think, are going to be more likely to be wearing masks moving forward, particularly during respiratory viral season. And we should be supportive of them, and we should be kind and aware that this is something they need to do to really protect themselves. Because if they get COVID, they can get into serious trouble. If they get adenovirus, which is another respiratory virus, they can get into serious trouble. So we're going to see masks still moving forward. Do we need to use mask mandates and large, forcing people to wear masks? We might someday in the future, but I can tell you that it's a tool that we should pull out only if we really have to. And during the COVID pandemic, we did have to do it. And there were tools we used to help open schools. And we were tools to help protect people in workplaces. I think things would have to be pretty serious for a mask mandate to come back in again. We'll have to leave it open, but that's the tool we need to leave in the toolbox, but pull it out only if we have to in the future. But they do work. I'll tell you masking works. It's a little bit hard to prove how well masking works in a community because those studies are really hard to do. But the predominance of data says they're useful. One thing we learned during COVID that took us by surprise was the impact of closing schools. So let's talk about that for a minute. The reason why we were fairly quick to close schools with COVID goes back to what we've learned from influenza. Particularly what we learned from influenza back in 1917-18 and in 1964, the Hong Kong flu, I think it was, which I had. Maybe it was 68. And then our subsequent swine flu. Influenza spreads relatively rapidly through kids, and it can be really, really hard on them. And for influenza, our children are kind of the petri plates and vectors that bring home influenza to the household. And then when they get it in the household, grandma or somebody else who's vulnerable who gets flu can get really seriously ill from it. So school closures have always been talked about in public health through the ages as something to help control spread of contagion. And every now and then we've had to close schools because of flu. Occasionally we had to close them because of whooping cough and other things. So it was thought that the right thing to do was to close schools with COVID. I think early on in the pandemic, while we were figuring things out in April and May, that closing the schools, I think, were the right thing to do to protect our kids and protect our families. But the school closures largely in the United States went too long. And because as we learned that masks can protect our kids in schools, and as we learned more about testing, and we were able to test people, and we had our testing more available, which was in the fall of 2020, schools and several private schools were open and did fine. I think some of our public schools stayed closed too long. And we're starting to get more information now that this really set our kids back. It set them back socially. It set them back in their education. And we got a lot of catch up to do now to get our kids caught up again. And so I think that's a lesson for the next pandemic that we really need to approach our schools and how we work with them wisely and try to keep our kids in school as much as possible. I feel very strongly about that. Some other things that we now have a drug, Paxlovid, that does reduce hospitalization due to COVID, and it does alleviate symptoms, and it reduces shedding of virus. And people, particularly people who are older, have underlying health problems or immunocompromised should take Paxlovid. Younger people, the impact of it is not quite as strong because most of the younger people will do well. Anyway, if somebody's never had COVID before, if they've never been vaccinated, I think that would be somebody I would treat, even if they're younger and healthier. But if they've had COVID or vaccine, I don't know how strongly I feel about having to treat them. There'll be some other treatments coming down the pike. Some of them may be better than Paxlovid. We're still trying to figure out what the rebound is, where sometimes people who take Paxlovid will have a rebound of COVID again after they stop the medicine. And so the instructions on how long to take it might change some, but we'll have to wait for the studies to come out and see. The other thing is testing. So if you remember early in the pandemic, man, you couldn't get a COVID test anywhere, anyhow. There weren't many of them out there. We learned that we have to be ready to produce testing for emerging infections fairly quickly. And everyone was sort of assuming the CDC was going to do this for us. They didn't. It was really private industry that stepped up to fill the void fairly quickly. I think we learned that we need to use our existing technology and our existing companies that do testing all the time to make the tests and not rely just on public health. Testing now is readily available, and point-of-care testing, you can get it in doctors' offices. You can do it at home. You can buy it down at the drugstore and do it at home. The home tests are largely good. I think they're not quite as sensitive as some of the tests we'll use in healthcare settings, but they're good enough, and they're quite helpful. People need to know how to use those tests, and they need to know if they test positive for a respiratory contagious disease, they should lay low for 5 days or so if it's COVID, until they don't have a fever if it's flu, until their symptoms start to go away if it's one of the routine cold viruses. So I think we're going to start seeing more home testing available for all sorts of infections and problems. And that's a good thing. I think we learned during COVID that we can do it, and we can do it reliably. The one problem with home testing is going to be, starting in May when the emergency declaration goes away, the distribution of free home tests is going to be also going away. And so you'll have to pay for them. For the first year after the end of the emergency declaration in May, the insurance companies are still going to be required to pay for them, at least a certain number of them. The other thing in home tests now, we will start to see very soon in our pharmacies and other areas and online, a combination home test for flu and for COVID. Maybe in the future there'll be some other viruses tacked onto that. So how would you use that? Well, you wake up in the morning, you got a sore throat, scratchy throat, bit of a runny nose, low-grade fever. It's respiratory viral season. Is it flu or is it COVID? Well, you're going to know. Why is it important to know and differentiate? It's because the treatment is different. Paxlovid for COVID, Tamiflu or one of the others for flu. So you can, particularly if you're a vulnerable person, you can treat it. And you also know how long to quarantine or isolate. Right now it's 5 days for COVID, or until the fever resolves for flu. So it does help guide us, and it also helps your family plan a little bit and know what to do. So that's sort of where we're at right now. I can't tell you 100% for sure that this slide in endemicity is going to be free of all bumps. You never know. We could get thrown another weird variant at us. Hopefully it won't be a weird variant that's more serious than the current Omicron XBB 1.5. But if it is, we need to be ready to respond to it. So where are we at with flu? You know, that we're kind of in a valley. We're still seeing influenza in our area here in the Triad. We follow this at Wake Forest Baptist Health. Our numbers are kind of plateaued a little bit, but they're not extremely high. It wouldn't surprise me if they don't start to go up a little bit towards the end of March. As COVID declines, the flu might come up a little bit more. We'll have to see. But the vaccine's a good match for it this year, the flu vaccine. I don't anticipate huge problems if it does go up some. But if you get particularly if you get a fever, body aches, headache, bit of a cough and a sore throat here in the next 3 weeks, it might be flu. RSV is pretty much gone right now, but we have some other respiratory viruses that are circulating. The big one is the common cold virus, actually, rhinovirus. So if you got a stuffy nose, no fever, and you test negative for COVID, probably got a cold virus. But those should be starting to decline some too. Because our respiratory infections are going down, and we're seeing less COVID, all our healthcare facilities in our area, including Atrium Health, Wake Forest Baptist, are lifting their visitors restrictions. And so kids can now visit in the hospital if they have loved ones or family members. But be a good citizen. If Johnny's got a snotty, runny nose and isn't feeling well, it's probably best for him to stay home. So let's try to keep visibly ill kids out of the hospital still. So I think that's the major things. One last thing I'm going to mention, but I'm not going to spend a huge amount of time on it. A lot of stuff in the media over the last week or so about the origins of COVID. Where did it come from? Well, first of all, it's not the origins of COVID. It is the origins of SARS-CoV-2, which is the virus. COVID is the disease. So it's a bit of a misspeak on people's part. That virus emerged, and we know where. It emerged in the city of Wuhan in China. And there are two theories that are battled about as to where this came from. And it depends a little bit almost on one's political persuasion, which theory you believe. One is the, quote, lab leak theory, and the other is the natural animal to human jump. I mean, there are other theories out there too, but these are the two main ones, and the ones I'd like to talk about. So let's talk about the, quote, lab leak theory. First of all, both of these are called theories, which means we're postulating, we think. We might have some thoughts or evidence for both of them, but they're still theories, and neither of them have been conclusively proven. But let's call the lab leak theory. Let's find something else to call it, because viruses don't, quote, leak out of labs. It's very, very, very unusual for a virus to actually escape from a lab through the ventilation or get out the door, or somebody left a window open. That just doesn't happen. What it would mean is that there could have been a laboratory exposure of one of the workers in the lab to the SARS-CoV-2 virus, and they picked it up, had 2 or 3 days of no symptoms, and then went out into the community, got sick, and then transmitted it to somebody else. That theory is plausible. It could be that it happened. I haven't personally seen any evidence that supports that, that's been circulated in the scientific circles. Now, the FBI thinks that's what happens, and the Department of Energy thinks that is what happened. Maybe they know something I don't know, but I haven't seen that in the scientific circles or in epidemiology. The other theory is that it jumped species, and that it wouldn't be the first time that a virus has done that. I can tell you that of a list of 20 of emergent infections that we have seen in the last 2 or 3 decades, 90% of them got into the human population from an animal. And these are called zoonotic infections. And it happens. The big one out there is the flu. The flu is an animal virus, particularly of birds, but also of pigs and horses. If you remember in 2009, we had a swine flu pandemic throughout North America, and that came out of a pig eventually, and then infected a human, and then got down into Mexico and then came up to North America. So that was a species jump. The Spanish flu back in 1718, that was a species jump. SARS-CoV-1, the SARS that we had back in 2003, was a species jump. And that was a species jump from bat to an intermediary mammal host in a wet market, of all places, which is a market where you go down and you buy a live animal and you have them butcher it there, or you take it home and butcher it yourself. It got into a live market there, and that's where the SARS-CoV-1 pandemic came from. And that was a coronavirus. And so that theory, so there was a wet market in Wuhan, a pretty good sized one, and it turns out that they were doing some things as far as having certain animals in there that they weren't supposed to be having, because we know that certain mammals are pretty good reservoirs for certain viruses. But it turns out that they were in that market, even though they weren't supposed to be. And we also know that the virus, there's a coronavirus that looks very, very close to SARS-CoV-2. That's a natural virus that hangs out in bats in and around Wuhan. So the theory goes is that the bat gave it to an intermediate animal, such one of these animals that weren't supposed to be there, and then through the butchering of that and that infected animal, people were exposed. There are two studies that epidemiologically suggest that that's what happened. Normally, we would, if we have evidence of that, what we do is we go in and then we try to find the virus in environmental samples and in the animals that were actually on the market. And we lost our chance to do that because China wouldn't let the WHO in to do that. And by the time people finally were able to start studying that and look for that virus in that market, it had been scrubbed clean. And the animals that weren't supposed to be there were all gone. And so we couldn't prove it. SARS-CoV-1 we did, because we got into the market and we figured out how the bat to animal to human transmission happened. In fact, we even know the first human who got it. But we lost our chance with this one because of a lack of transparency. But we'll see. There still are some more epidemiologic tools and studies that can be done with this. My personal opinion is that I go with the natural bat to animal to human, so the natural species jump, because I've seen it before, and Mother Nature is pretty good at doing that. So that's my opinion, and I'm sticking to it for right now until I see more data. So with that, I don't know if anyone sent in any questions, but...
Yes. We had a couple from Facebook. Do you think the FDA will recommend twice yearly vaccinations for high-risk groups and those over 50?
Right, yeah. So what are we going to do about booster vaccine? We're still talking about it. So it'll be the FDA and the ACIP, the CDC, who decide that. And what's been proposed and what the FDA has proposed is that every year, roughly in the May time frame, we see which variants are circulating and then prepare a booster vaccine for that, and that booster vaccine be given in the fall. For immunocompromised people and for people who are perhaps over the age of 70, I'm not sure what age they'll pick, that booster might be twice yearly. But it's still being discussed and studied, and so we don't know 100% for sure. I think that we'll probably see a booster vaccine available in the fall that would be in line with what the current variants are. But there's pros and cons on both sides to it.
you got the September fall COVID booster, are you fully covered up at this point, and you have the most recent, latest, and greatest?
Yes, if you got vaccinated after 1 September with the booster, you have the Omicron BA.4/5 bivalent vaccine, and it's doing pretty well for the XBB 1.5. We know for at least 3 to 4 months it gives pretty good, robust protection from serious disease, and we're still following it out. You can talk if you're immunocompromised, if had a transplant or seriously immunocompromised. You can talk to your doctor about getting it again now this spring, but otherwise, I don't think you need it right now. All right. Well, we'll come back from time to time as things change and we have new updates. And so 3 years, and I really appreciate everybody who's been following, and I appreciate everybody's kind words that I've gotten over the last 3 years for what we've been doing.